CataractCoach.com, aphakic for 3 months. That means that capsular bag is fibrosed and contracted, and the patient's got some zonulopathy. Now, this is a tough case. So the patient had an attempted cataract surgery done 3 months ago, but there was noted to be some intraoperative zonulopathy, so the surgeon abandoned it and then referred the patient out. The problem is the original surgeon waited 3 months, and now look at this fibrosis. You even have the iris causing some synechia, being adherent there to the anterior lens capsule. And you can see what used to be a normal little rhexis has now contracted down because, again, there's nothing in the capsular bag. So here's using viscoelastic, like a dispersive agent probably initially, to then try to open up the capsular bag. But the problem is the bag is contracted. It's less elastic now. And you have the anterior and posterior leaflets kind of getting glued together. If you are going to leave a patient aphakic initially for some trauma like this or problem, refer the patient to another surgeon or do a reoperation within a week or two, maybe 3. Certainly after about a month, you can see you'll get a lot of fibrosis. And this is 3 months where it's really difficult to do anything. So again, trying to go inside here with a spatula. Now, there's another option. Well, that other option is you can just put a sulcus lens in here and then opt to capture it because that rhexis looks so thick and fibrotic and strong. You could probably just opt to capture it there, open the posterior capsule. So let's see, here's another paracentesis going in there. Not sure about the extent. Is the capsular bag intact still? So here's using micro scissors. Obviously, the video is edited. This is not a fast procedure. This takes time. And you can see it's just over and over again trying to get some dissection here with the viscoelastic to get that bag open. And again, maybe a better part of judgment, at least maybe for me, would be just put the haplix and the sulcus for a 3-piece lens, opt to capture behind that, and you could even open the posterior capsule if you needed to. And to get that completely captured, because I don't know if you're going to separate the anterior and posterior leaflet. So again, if you did the optic capture, you're putting the optic behind that fused anterior and posterior capsule. So you'd be opening up that central posterior capsule and getting the optic behind that. And again, it looks pretty strong. Now, if you don't do that, if you try to open the bag up, remember, patient did have zonulopathy. And let's take a look, see if we can figure out where that zonulopathy was. So again, here more viscoelastic, slowly but surely getting it open up. Another para. Now we've got 4 paras, you've got full access here. And that's an important issue here. Starting off with 2 paras, 180 apart is good. But if you really need that extra access, having the 4 paras so you have them 9 degrees apart is really quite helpful here. So now let's see. Making, looks like a groove there. And okay, looks like making a Hoffman pocket basically. Going towards the sclera here and making a pocket at this point. So that's probably where the area of zonulopathy was noted to be. That looks like a good little Hoffman pocket there. Get some BSS and wash away some of the red stuff there. Get that heme out of the way so we can see what we're doing. And there we go. Now we're talking. And now here comes, okay, a Cionni ring. So here's the Cionni ring. And now making your incision with the keratome, getting the Cionni ring inside the eye. Going to get it in the capsular bag. I like the two-handed technique here with the forceps in the right hand, the microforceps, and then the Sinski hook in the other, and just getting that broad around. Can you get it all the way in? And then again, you want to have that eyelet right there where you made the Hoffman pocket. And now here going back, looks like a Prolene, probably a 10-0, maybe a 9-0. And that looks like the long CIF4 needle. If you get that pushed in there, now you can bring it out. And so there we go, externalizing the suture and do it on the other side as well. And then you're wondering, where are you going to tie this? Well, remember, that's the Hoffman pocket. You're going to bring both those suture ends out through that Hoffman pocket you created, that incision right at the corneal-limbal junction. So push that through as well. And that way you have a suture that's already nicely buried. So there's the Cionni ring, which looks pretty darn good. Now, again, you want to get that eyelet above the rhexis. Here comes the IOL. Get that into position. And then let's see how you tie that up. You're going to get it in the bag completely. So the whole bag's intact, looks like. Okay, get that in there, get that trailing haptic in as well. Now, we learned our lesson here. Don't leave them faking for so long. No, here you go. Look, that's a Sinski hook or any kind of hook. Bring them out, those 2 suture ends, and now you can tie them up, and that knot slides right back into that Hoffman pocket. That's smart technique here. I like it. Look at that, suturing that up just like that. And here comes the other side. And get it all secured. And that looks pretty darn good. So I think we definitely learned our lesson here. So if you have a patient, you have to leave aphakic. Do not leave them aphakic for 3 months. In fact, I'd say a month is your maximum. And the sooner the better. Even if it's a week or 2, that's ideal. Get help from your colleagues. We can all do these cases together. We're here to learn together. Remember, CataractCoach.com. Submit your video, but you better follow the directions exactly. Go to CataractCoach.com to read them.